So coming to the next point, cardiovascular monitoring of the patient's surgical patient. This is important part. Cardiovascular physiology you have to understand. In this, what are the things which need to be monitored in a surgical patient? So blood pressure is regulated by systemic vascular resistance and cardiac output. If you see what is blood pressure, it depends upon systemic vascular resistance. Vascular resistance means how much the vessels are constricted or dilated. In sepsis, there is vasodilatation, so systemic vascular goes down, so blood pressure goes down. Cardiac output, blood pressure is means it is multiplication of carbon dioxide, cardiac output into systemic vascular resistance. That gives the blood pressure. So, in any shock, hypovolemic shock, the body tries to vasoconstrict. That increases the systemic vascular resistance. That increases the blood pressure. So blood pressure is product of cardiac output and systemic vascular resistance. This concept you have to understand. Then only you will think cardiac output means amount of blood pump with each contraction, ventricular contraction. What is cardiac output? Actually, cardiac output is this stroke volume into heart rate in a minute. And what is stroke volume? Stroke volume is how much amount of blood is pumped from the left ventricle. So it is the difference of end diastolic volume and end systolic volume. So initially the heart is in diastole, the amount of blood is filled, for example, is 100 ml blood is filled in this, and in one stroke the blood is pumped. So after systole, how much volume is remaining? Suppose 30 ml. So how much stroke is that? That is 70 ml. So stroke volume becomes 70 ml. So it is in a single stroke, and if you multiply it with the heart rate, that becomes the cardiac output. And what is blood pressure? Blood pressure is a product of cardiac output and systemic vascular resistance. So systemic vascular resistance is also important, and cardiac output is a product of stroke volume and heart rate. And what is stroke volume? It is the difference or amount of blood that is pumped. So systemic vascular resistance and cardiac. Peripheral vascular depends on compliance of the blood vessels and predominantly the arterioles. Cardiac output is measured by multiplying stroke volume and the heart rate. And stroke volume depends upon the venous return, means how much blood is filled inside. That is the important thing. It is Starling's law. Initial, how much blood was there? So systemic, first of all, let's clear the systemic vascular resistance. The systemic vascular resistance depends on vascular compliance and hemodynamics of the blood flow. Factors such as heart rate and stroke volume affect arterial pressure by altering cardiac output. So cardiac output is equal to heart rate into stroke volume. The less compliant the system is, if the arteries are very stiff, the more work heart must do to given stroke volume. Compliance decreases with age. When elastic fibers are partially replaced by collagen, there is decrease in number of smooth muscle cells in arterial walls. So that stiff arteries decreases heart compliance with the age. Age and stiff arteries both decrease the compliance. That leads to more work on the heart to pump same stroke volume. So that's why blood pressure increases. The compliance decrease. So rate, the in and out. So you can see this basic vascular pathology. The blood pressure increases because of that. Pressure is in the arteriole depends on the rate of blood entering and rate of blood leaving. So rate of blood is entering and rate of blood leaving. If suppose the rate entering and rate of blood leaving the system, the compliance of the vessel, flow of the blood through the vessel system requires pressure gradient to be generated across the area. Stroke volume, this is important, depends on many factors. Cardiac cells, muscle cells, similar to skeletal muscle, are made up of sarcomeres. Sarcomeres contain thick filaments, myosin, and thin filaments, actin, and these filaments slide each other and so shorten the sarcomere. Therefore, shorten the force that muscle sarcomere can exert depends partly on the length of the initial length. Whatever, if it is more there, more will be the volume. When sarcomere is very short, the high degree of overlapping fibers with contraction force. When sarcomere is very long, the relative lack of overlap means that less force can be exerted between the two extremes. A length of sarcomere exists where the overlap is high enough to maximum force but not high enough to interfere with force production argument. Starling law, maximum force exerted by the ventricle to pump the blood depend on the maximum length of the cardiac muscle. This is the Starling law. So what happens? Starling law curves. Afterward, if end diastolic volume more, if diastolic volume increases, then afterward it will be not, force cannot be increased. This is for force that heart can exert to a pump blood, known Frank Starling mechanism. End diastolic volume refers to the amount of blood that ventricle of the heart holds at its maximum just before it contracts. That is end diastolic volume. Regulation of stroke volume. Stroke volume can be regulated by preload, which is dependent on what is preload now. Try to understand this. Preload. Regulation is by preload. Preload is venous filling time. It depends on what are the factors on which preload. Filling time, if suppose venous filling time is reduced, so preload will be less. Diastolic filling time. One is venous filling time, second is diastolic, then third is atrial, systole, myocardial or distensibility, compliance. These are the things which define the preload. Second is contractility, heart pumping capacity itself, which is increased by preload. Nerves, sympathetic stimulation, hormones, adrenaline, thyroxine, glucagon, or drugs, inotropic. They can increase the contractility, which can be decreased by, when is decreased perfusion, contractility may decrease. Ischemic disease, acidosis, alkalosis, parasympathetic stimulation, vagus stimulation, electrolyte imbalance, hyperkalemia and all this, they may decrease. Drugs, anesthetic drugs, they can decrease the contractility. So the stroke volume depends on preload, contractility, and afterload. These are the three things that decides the stroke volume. And stroke volume into heart rate will give, stroke volume into cardiac output will give the blood pressure. Cardiac output will be a stroke volume into heart rate will be cardiac output, and cardiac output into systemic vascular will be blood pressure. So the important thing is this one, cardiac output is very important. How much blood is coming out of the heart, and this will go to the body. That is, heart rate can be increased or decreased because of drugs, but stroke volume depends upon these factors. That's why the stroke volume has got dependency on preload 1, contractility 2, third is afterload. Preload depends upon filling time, diastolic filling time, venous filling time, atrial systole, heart compliance. If suppose there is atrial fibrillation, there will not give any. If there is ventricular tachycardia, so filling time will be decreased, venous filling time will be decreased. So all this contractility depends upon preload, how much sympathetic stimulation, decreased by hypoxia, decreased by drugs. And afterload is whenever you are trying to pump, there is obstruction. Maybe it's aortic stenosis at the start, maybe increased systemic escalation because vasoconstriction is there, maybe increased ventricular volume, greater tension to contract, or increased cardiac work. And afterload can be decreased. Whenever you are trying to decrease the afterload, it means more cardiac output can be done. Vasodilator drugs means you are reducing systemic vascular resistance. Vasodilator, septic shock, mediators. So cardiac output is dependent on heart rate and stroke volume. Now heart rate is dependent on, controlled by autonomic nervous system. Sympathetic through CA to T5. It secretes noradrenaline. So cardiac beta receptors, that causes increased heart rate. Parasympathetic, vagus, acetylcholine, muscarinic, decreases heart rate. Autonomic nervous system, sympathetic, from T8 to T8, cervical C8 to T5, causes non-adrenaline release at the nerve ending, which acts on cardiac beta receptors, increasing heart rate. Chronotrophic as well as inotropic. Chronotrophic means increased heart rate and contractility. Both these causes. So beta adrenaline, noradrenaline is a good sympathomimetic. This is called a sympathomimetic. Parasympathetic, acetylcholine, nerve ending, causes muscarinic receptor, slowing of the heart rate. Control of blood pressure. In short term, blood pressure controlled by neurological mechanism with reflexes that detect abnormalities and respond rapidly. Long term control, regulation of blood pressure accounted by regulation of blood volume by the kidneys. So that is short term by the baroreceptors and chemo there, and long term by the kidneys. Short term regulation by autonomic nervous system. System sympathetic increases blood pressure and heart rate, increase cardiac swell. Parasympathetic decrease heart rate, cardiac output. And baroreceptors but autonomic nervous system, and baroreceptor, aortic arch, medulla, vasomotor center. Arterial BP sensors. Now arterial BP sensors. Mean arterial blood pressure monitored by primary in the aortic arch, in thyroid sinus, the immediate response in the blood pressure getting up in the chair, and the postural hypotension. These sensors are temporarily different but increase reflex one thing. So these are arterial. These are present in the carotid sinus and aortic arch. Carotid sinus is more sensitive. Information from the brain transmitted by the medulla oblongata, where vasomotor center and cardioinhibitory centers lie in the different response. The vasomotor center predominantly activates sympathetic nerves to increase BP, increase heart rate and contractility, release adrenaline to cause vasoconstriction, and increase systemic resistance. The cardioinhibitory center activates vagal parasympathetic centers, slow the heart rate, reduce the cardiac, decrease the blood pressure. This is parasympathetic. Increase in arterial pressure results in decreased sympathetic output to the vasculature, decreasing system. So decrease system. So BP decreases, sympathetic stimulation causes vasoconstriction. BP decreases. This is the rate by which the range in which two types of baroreceptors are active is different. Carotid sinus baroreceptors have lower range. So carotid sinus baroreceptors have lower range, 60 to 180. Have a lower range of 60 to 180, and aortic baroreceptor detect higher pressure rates, 90 to 200. Low pressure is detected by carotid and high pressure is detected by aortic. Venous BP, the baroreceptor located in the great veins, atria, pulmonary trunk, are stage sensitive to changes in the blood volume. They detect the blood volume, then pressure. Increased stretch of this receptor reduces sympathetic output and promote vasodilatation. In addition, Bainbridge reflex results in decrease in heart rate. So this is Bainbridge reflex. Renin, venous baroreceptors, atrial, pulmonary detect blood volume. So the third is angiotensin. Renin acts on angiotensinogen, converts into angiotensin 1, angiotensin to angiotensin 2 in liver. Then 2 is converted to, this is in lungs, this is in liver and kidney. Kidney, liver, this is lungs. They causes aldosterone secretion for adrenal cortex, retention of water, and also vasoconstriction. Chemotherapy from aortic is sensitive to tissue oxygen and carbon dioxide level. Low oxygen pressure in low arterial pressure results in poor tissue perfusion, activation of the receptor and promote vasoconstriction. Hormonal control of blood pressure, catecholamines. Sympathetic stimulation to adrenal medulla results in secretion of catecholamines, which cause increased heart rate, contractility, and peripheral vasoconstriction. So when adrenal medulla is stimulated, it increases catecholamine, heart rate, and contractility. Antidiuretic hormone released from posterior pituitary causing vasoconstriction, renal water absorption to increase the blood volume. Long-term regulation of BP, long-term changes in blood pressure, primary mediated by hormonal factors, control blood volume, regulation of sodium moderation, path that escape, renin, angiotensin excess decreases blood pressure, increase renal blood flow, extra renin, angiotensinogen is secreted in the kidneys, angiotensin is converted to angiotensin 1, and 1 is converted to 2, 2 is causes secret of aldosterone and increase the BP. Natriuretic peptide, blood volume changes in natriuretic peptide from the right atrium. The second natriuretic peptide, brain natriuretic peptide, is synthesized within the ventricle. One is in right ventricle, another is in the ventricle, and apparent release the same mechanism has similar physiological. These peptides use clinical diagnosis. The neuropeptide involves in long-term regulation of sodium and water balance. These hormone decreases aldosterone. They decrease aldosterone release by increases GFR. They increase GFR, produce natriuresis and diuresis. Opposite to ADH, it is acting and decreasing angiotensin 2. So this is causes therefore reduction in volume and therefore ECG and cardiac conduction. Cardiac conduction. The heart has three different types of excitatory tissues. One is atrial muscles, second is ventricular muscles, and third is specialized conducting tissue. Heart also has a large number of mitochondria. This means that energy for heart muscle can be generated by aerobic metabolism. The rhythmic spontaneous depolation occurs in cardiac tissue. SA node and AV node of the heart have highest rates of spontaneous activity, but cardiac muscle itself has intrinsic activity. So no stimulus is necessary to cause depolarization in the cells. This is because cell membrane is relatively leaky to sodium ions, and sodium ions leak into the cells. Resting potential rises and depolation occurs spontaneously. In addition, calcium ions in the cytoplasm, large quantity of calcium ions also diffuse into the tubules, have a greater diameter and skeletal muscle involved. Free intracellular calcium ions are most important factor regulating contractility of the muscles, and intracellular calcium will increase force of myocardial contraction. So decrease and increase calcium will increase, decrease calcium will decrease. Many drugs that increase cardiac muscle contraction involves increased intracellular calcium. For example, cardiac glycosides inhibit sodium ion and myocyanate response by pumping out sodium in exchange of calcium. This loads myocytes from the calcium and increase force of contraction. Catecholamines also increase its influx into myocytes, whereas acidosis reduces it. What is ECG now? Now here what you have seen, it has got a automatic stimulation, SA node, AV node, and this has got leaky sodium, so it's spontaneous. Then calcium is the important role. ECG records sum of electric impulses generated by the heart during depolarization and contraction. Provides information, rate and rhythm of heart contraction, as well as information pathological process, infarction, inflammation. It is a 2-lead ECG based through the extension of direction of electric flow. Based on the extensions of direction of flow from the heart, which can be a positive deflection on ECG, shows the electric current is flowing towards the electrode. Positive is towards the electrode and negative is away from the electrode. Parts of ECG and waveform is like this. So if you see AVR and AVL, AVL you are measuring from this side, AVR from this side, and lead 1 is from this side, lead 2 is from this side. If any positive deflection in AVF, you are measuring from below. So instead of going, it is the lead 2 is from the left, AVL is from the upper left, AVR from the upper right, AVF from the foot front, AVF front, left, right. Lead 2 is from the left. Depolarization of the atria. P wave is because of depolarization of atria. 0.7 duration. Depolarization is hidden in QRS complex. Atrial depolarization is V. And ventricular depolarization is QRS complex. Depolarization of the ventricle is QRS complex. First deflection downward is Q wave. First upward deflection is R wave. Usually has increasing amplitude V1 to V6. So it goes on increasing. As S wave in the lead 1 suggests right axis deviation. S wave in lead 2 suggests left axis deviation. A wide QRS occurs when depolarization does not pass down the Purkinje fibril, as in bundle branch block and complete ventricular origin ectopics and third degree bird block. PR interval represents the conduction delay between atria and ventricle should be represent the first degree block. A variable of PR occurs in secondary block. T wave represents the depolarization of the ventricles. ST segment the period between S wave and the T wave, usually isoelectric, may be elevated myocardial infarction, may be depressed myocardial ischemia. ST segment normal despite the presence of either infection or ischemia. Post-operative monitoring. What you are going to monitor in the post-operative case? See, this is just now the ECG, isoelectric normal. ST is electric normally, elevator depressive myocardial infarction, myocardial ischemia, repolation of the ventricles is the T wave, and QRS this. Pre-operative monitoring, you need a pulse, blood pressure, respiratory, oxygen saturation, temperature, urine output, ECG. Additional invasive monitoring is central venous pressure, arterial blood gases, Doppler, Swan-Ganz, pulse and BP monitoring, anesthesia maintenance, recovery, manual sphygmometry, ECG monitoring, monitor. Pulse oximetry has to brain saturation is not a major, not partial pressure of oxygen. Oxygen measures oxygen saturation. It is not partial pressure of oxygen. It is not PaO2. It is just oxygen saturation. Probes are attached to the higher fingers or earlobes, contain 2 light emitting diodes and 1 detector. Infrared lights, the constant background amount is absorbed by the skin. Venous blood flow and fat may change. Venous blood flow and fat may change the blood flow. The constant amount is subtracted and total absorbed to the oxygenated blood are differing amounts in calculate to wavelength. The instrument is able to calculate the percentage of oxygen saturated from the ratio. Skin pigmentation does not affect it. However, observation of the hemoglobin distribution curve may show that significant fall in PO2 occurs before SaO2 decreases. Problems with the oximetry, what is there? Calculations are made from number of pulses, so there is a delay of 20 seconds. Atrial fibrillation may not give it properly. Hypotension, tricuspid abnormal hemoglobin pigment, carboxyhemoglobin, and all this. Therefore, produce false elevated interference, movement, shivering, and all this may interfere. Poor tissue perfusion, nail varnish, pulse oximetry only measures HB saturation, oxygenation, not ventilation. CO2 content of the blood is reflected by ventilation. Renal perfusion linked to cerebral perfusion. Urine output is good indicator of renal perfusion, thus oral fluid balance. Catheter and hour urine mandatory. Hourly urine measurement is mandatory in massive fluid loss, shock patients, major cardiac vascular surgery, surgery in jaundice patients, pathology. Invasive monitoring is intra-arterial BP monitoring. Indications for intra-arterial critically ill patient, shock wave, major surgical patients, induced drug-induced pheochromocytoma induced hypotension, they require frequent blood gas energy. Monitoring use of inotropes. Complications is CVP monitoring, embolism, hemorrhage, arterial venous, AV fistula, formation, distal limb ischemia, sepsis, tissue necrosis. So central venous monitoring, central venous pressure, intra-arterial BP monitoring. So now central venous pressure monitoring is guide to circulatory volume. Myocardial contractile lines are normally placed in the tip of superior vena cava from internal jugular vein or subclavian vein. Approaches using ultrasound guided centimeter. The normal CVP is 8 to 12 millimeter of centimeter of Hg. This is the normal CO2. CVP can be read intermittently with a manometer. Continuing transducer oscilloscope, it is essential when the measurements taken. CVP line can be used for administering total parenteral nutrition or toxic drugs, chemotherapy or radiation. There are certain clinical patient. Fluid challenge in CVP monitoring. CVP is more useful trained to rapid administration of set of fluid volume rather than absolute number. The assess the compliance of vascular system. The endpoint is returned to the blood pressure. For example, urinary representing normal, poor response in BP or tissue perfusion, adequate feeling. Complications CVP line, common complications, sepsis, pneumothorax, incorrect placements, brachial plexus injury, phrenic nerve injury, carotid subclavian artery rupture, uncommon tension, pneumothorax, air embolism, pneumothorax, tracophysial Doppler measurement, ultrasound can be these multiple cross pulmonary artery wedge pressure, Swan-Ganz catheter may be required when CVP does not correlate with the pressure in the left atrium. As in the following condition: left ventricular failure, interstitial pulmonary edema, valvular heart disease, chronic lung disease, pulmonary hypertension, pulmonary embolus, left ventricular Swan-Ganz catheters, 4 lumens, distal tip. There are also values for calculation of the cardiac output and sphere. Most catheters are at least 4 lumens. Distal lumen and the tip which lie in the peripheral pulmonary artery, proximal lumen lie 25 cm from the tip which should lie in the right atrium. Thermistor lumen, which is used to measure the temperature. The catheter is inserted into central vein connected to the oscilloscope, advanced into the right atrium. The balloon is inflated and then air and floated in the right ventricle and pulmonary artery. Further advancement will occlude the pressure of the pulmonary artery and cause wedge waveform. When occluded, there is a column of fluid from the end of the catheter to the left atrium and it measures right atrium, right ventricular, pulmonary artery, wedge pressure. Distal tip is pulmonary artery, proximal tip is in right atrium, 4 lumens, third is the balloon, fourth is the thermistor. Balloon. It can be measured cardiac output by thermodilution fixed principle, and one is known. It can use cardiovascular measurement, central venous pressure, pulmonary wedge pressure, pulmonary mean arterial pressure to calculate the SVR, pulmonary pressure, ventricular stroke volume. A bolus 10 ml cold dextrose is injected and thermistor at the tip. A temperature drop proportional to the cardiac output. Knowledge of the cardiac output and SVR is useful to determine if critical patient whose shock and myocardial infarction cause for 10 ml cold saline injected. Measurement of cardiac output. Pulmonary is first reliable monitor for cardiac ITO. Once the cardiac output is measured, the stroke volume can be calculated from the data and arterial line and cardiac continuous cardiac output from the body rather than using cold bolus of the fluid as indicated coil around the catheter warms. Catheter warms the blood as it flows and drops in the temperature. It is analyzed continuously. Thermodilution from the cold fluid injected CVP line analyzed via modified arterial catheter. But double indicator methods to draw fluid. Lithium dilution is also another method. Process pulse contours analysis, fixed principle. So these are so much details of the pulmonary artery wedge pressure. So PAWP, there are 4 lumens. One, the distal is in the distal tip is the pulmonary artery, proximal is in the right atrium, 25 centimeter from the distal. Then balloon is there to inflate and to cause is wedging. Then there is thermistor to measure, and you put a cold saline from the distal tip, 10 ml cold saline. So coming to next topic, it is ventilatory support, anatomy of thorax. Thorax consists of 3 parts: manubrium, body, and xiphoid process. Ribs, heads, you see this is the like this costal cartilages, like last 9 and 10 run another articular stump, the intercostal spaces, 3 muscles, external, internal, innermost, transverse. It is like this: external, internal, and innermost. So this anatomy is important: outer, external, intercostal, plus serratus, anterior posterior muscle, and levator costae. So transverse, thoracic, and subcostal muscles. What is the important thing in this? If you see, this is the pulmonary artery, pulmonary veins, lowermost is pulmonary vein, right aspect, right lung. You see this one is impression of arch of aorta, left ventricle, grooves. This is anterior, this is the posterior side, and this is the left aspect. You can see anterior and posterior. External intercostal run obliquely forward, replacing internal intercostal are red, innermost intercostal. Then the vein, artery, nerve are between the innermost and internal intercostal. This is important. So there is again, after which there is pulmonary ligament is loose fold that hangs from the root of allowing movement of the lung during respiration. So nerve supply of the pleura is parietal pleura is intercostal and the visceral pleura is in left lung has 2 lobes, right lung has 3 lobes. So right lobar segment bronchi is straight and down, and left is very horizontal. 2, 4, 6. So again to measure 6, 8, 10 is like this, and posteriorly you get left and right. Respiratory physiology: prior to treating critical patient to maximize the degree of oxygen, the mechanics of ventilation and the process of gas action determine the partial pressure of oxygen. The partial pressure of oxygen determines the arterial content and relationship in described oxy-dissociation curve. Functions of airway depends upon the larynx, trachea, bronchi, and alveoli. Functions: the conduits of the vessel. The flow of gas depends on pressure gradient between the alveoli and the atmospheric pressure. Protection of the lung is filtered by nasal and mucociliary escalators. Of the upper airway. In addition, vocal folds, larynx, and protect the respiration. The action of inspiration. The muscles of inspiration. Diaphragm is the main respiratory muscle. External accessory muscles, scalenus, all that. So, what actions happens in the diaphragm? Contracts, flattens the dome, and ribs swing up and down. So AP lateral diameter increases because of pump handle movement, and bucket handle movement is transverse. Bucket handle increases the transverse diameter, and AP diameter increases with the pump. Pump is in the anterior and bucket is on the side. So these are the muscles of inspiration. Muscle used in expiration. Expiration actually is a passive because of elastic recoil of the lungs. Muscle for forced expiration. Sometimes if you want to do forced expiration, coughing, in that way, abdominal muscles are used, intercostal muscles are used. Action of expiration. Diaphragm relaxes. And lung and chest wall recoil. Normal expiration. Thoracic volume reduces. What is airway compliance? This is elasticity or stretchiness of the lung and refers to the lung and chest wall. Compliance is equal to change in volume divided by change in pressure. So if a high or good compliance means lungs are easily inflated. Poor or low compliance means lungs are stiff. Difficulty to inflate and do not. Poor compliance is caused by lung diseases, fibrosis, all these fibrosis, sarcoidosis, respiratory distress syndrome, ARDS, or by diseases of the chest wall, thoracic scoliosis. The surface tension is the surface area that tend to cause them collapse. To counteract this, minimal additional work is to reinflate. Pneumocytes produce surfactant. Is this again by what is work of breathing? Work of breathing usually performed during inspiration because expiration is a passive phenomena. Work to expand the lung against the elastic and surface tension forces. Work to overcome airway resistance and movement of the chest wall. Respiratory capacity. Capacity is dependent upon the volume of gas moved and respiratory rate at which. Respiratory volume, the amount of gas moved during respiration depends upon age, sex, build or fitness. Definitions of respiratory is spirometry. Tidal volume is air moved normally with normal quiet inspiration, expiration, tidal volume. Inspired reserve volume means whatever volume extra you can inspire after normal, that is inspired. Maximum volume inspirable, it is 3000 ml. Expired reserve volume, maximum volume expirable, around 2 liters. Reserve volume remaining lungs after maximum expiration, still there is some volume. Functional residual capacity is sum of expired reserve volume and residual volume gauge in which gases exchange can take place, that is functional residual capacity, FRC. Vital capacity is volume of air that can be expired after maximum inspiration. Force vital capacity. FEV1 is force expiratory volume of a first second of forced expiration. Total lung capacity is sum of vital capacity plus reserve volume. Peak expiratory flow rate is a peak expiratory depends cheap and easy measure of airway resistance. All of the above except residual volume can be measured by spirometry. To measure residual volume, helium dilution method has to be used, or whole body plethysmography. Respiratory volume rate, the amount of air brought into the lungs per minute is volume in respiratory minute volume. Minute volume is equal to tidal volume, respiratory volume. Not all inspired rate participate in the gas station. Some occupy dead space, anatomical mouth, nose, firing, alveolar dead space, physiological anatomical dead space, plus alveolar dead space, physiological atmospheric, practically zero. All CO2 expired in breath can be assumed to come in communicating with alveoli. So expired, and one can have Bohr-effect equation to compute diluting non-volume physiological space. Dead space usually accounts for 150 ml. Gas restriction depend upon ventilation. Alveolar ventilation is tidal volume minus dead space into an increase in dead space requires an increase in respiratory volume to minute. That is all. So now let's come to force expiratory volume in 1 second divided by FE ratio. What is force vital capacity? Gives an idea of vital capacity. It is reduced in whenever there is restrictive disease, FVC, force vital capacity. Deep inspiration, deep expiration, that will give the force vital capacity. If you do with the force that in restrictive disease, this will be decreased. So if denominator is decreased, the ratio of FEV1 to FEVC is definitely go up. If FE1 is the volume of gas expelled first second, it is reduced in obstructive. So upper numerator is reduced in obstructive type of disease, and denominator is decreased in restrictive type of disease. So FeV1, FVC. So this goes down in restrictive, this goes down in obstructive. So any obstructive disease, if denominator obstructive disease, if numerator goes down, this ratio will decrease. Normal ratio is, normal value is 0.7. If FeV1 is increased, obstruction is increased, it will go less than 0.7. If restrictive disease is there, it will go more than 0.7. This is simple. It is 0.7, means 70% of first volume is decreased. Obstructive FeV1 decreases, restrictive FVC decreases. Peak expiratory measurement indicates the airflow resistance but depends on patient's effort. Respiratory control is regulated by neurological feedback mechanisms, chemorreceptor stress receptors, neurological symptoms. Again, neurological control reception. Neurons controlling respiration are located in medulla. Respiratory center located nearby in the pons modify their activity. Inspiratory neurons have spontaneous rhythmic activity. Expiratory neurons usually inactive unless forced expiration is required. So chemoreceptor detect chemical changes in the blood due to either changes in partial pressure of oxygen or local concentration of the hydrogen, which may be generated by dissolved CO2. Centrally detect central medulla, central measure CO2, peripheral measure PO2. Central has got detects hydrogen ions as well. Carotid and carotid bodies, cranial nerves and primary detect PO2, less important. And glossopharyngeal and cranial nerve, they are in carotid. Primary detect PO2, less important detects PCO2. What are stretch receptor? This is hearing bureau reflex. Negative feedback mechanism from lung stretch receptor as lung inflates causes termination of respiration. Sends inhibitory impulse to vagus nerve to prevent overinflation. Physiology of gaseous exchange occurs by simple diffusion across alveolar capillary membrane. Also depends on solubility of the gas. Usually not readily measures using CO optic transfer. These are ventilation perfusion ratio, normal gaseous exchange, VQ ratio, alveolar ventilation rate, and alveolar pulmonary blood flow rate. Normal gas exchange requires adequate ventilation perfusion. Usually most alveoli will both ventilation perfuse. There is some functional redundancy in the system and healthy state blood flow is diverted in regions that are well perfused. This is ventilation perfusion match. If significant regions of lungs are perfused but not ventilated, there is decrease in the ratio with tendency of decrease in oxygen and carbon dioxide exchange, and therefore if significant regions of lungs are ventilated but not perfused, there is increase in ratio. So ratio when increases and there is region. The oxygen, this is now O2 curve. Oxygen is not very soluble in plasma, but mostly oxygen is therefore carried bound to hemoglobin molecules. Most oxygen is carried by hemoglobin. The small amount of oxygen dissolved in plasma, and therefore hemoglobin readily binds with oxygen to capillary interface and release oxygen into capillary tissue. It is capable of changing its affinity of oxygen under different conditions. Oxygen hemoglobin molecule is weights around normal blood concentration is 15 gram. Porphyrin ring attached to ferrous ring binds 4 molecules of oxygen per hemoglobin molecule. So 4 oxygen molecules per hemoglobin molecule, 1 gram binds 1.34 liter when fully saturated. Oxygen saturation refers to the number of oxygen bonds to hemoglobin expressed percentage of total number of available. So relationship between oxygen saturation PO2 is described by oxygen distribution curve. The sigma shape curve forms in a phenomenon is called cooperativity. When all sites are full and homogeneous saturated curve plateaus. When hemoglobin reaches the tissue and dissociation of molecules, the Bohr effect describes the factors that alter the position of oxygen distribution curve. The lungs, in lungs, CO2 diffuses from blood into the alveoli and hydrogen concentration falls. This pushes curve to the left, whereas quantity of oxygen that binds with hemoglobin is increased, resulting in saturation of the blood. When the blood reaches tissues, it absorbs the production of metabolism in carbon dioxide, and this increases oxygen concentration. The concentration of oxygen increases oxygen, and these factors shift the curve to the right, which favors the molecules and otherwise. Factors leading to shift to the increased affinity for the oxygen. So it is left, reduce affinity for oxygen, shift. So increase PCO2, all this. CO2 is transferred in 3 ways: dissolved in free CO2 plasma, Halden reflects the opposition, that is partial pressure of oxygen is increased, the amount of CO2 that is carried by blood falls. This is because deoxyhemoglobin is a weaker acid than, hence carry more CO2 in carbon hemoglobin. Halden effect reflects the observation that partial pressure of oxygen increases, the amount of CO2 that is carried by the blood fall. Oxygen consumption is equal to oxygen in arterial blood minus oxygen in venous blood, that is cardiac output. Normally it is 250 ml per minute. Arterial oxygen, this oxygen consumption is equal to respiratory investigation. Radiographs are most important in AP views. Remember the check the intratracheal tube and all this. Lung function test. Now what are the respiratory failures? There are two types of respiratory failure. Respiratory 1, there is only effect on PO2 and PCO2 is normal or decreased. So what is there in type 2? Respiratory deficient and pulmonary gas action sufficiently impaired causes hypoxia with or without hypercapnia. Wherever there is low PCO2, there is low PO2, oxygen, partial pressure oxygen low with normal or low PCO2. It is caused by disease that damage the lungs, primary tissue embolus. Type 2 failure is low partial pressure oxygen, high PCO2 caused by ventilation being insufficient to excrete sufficient COPD, exhaustion, restrictive airway, failure to compensate for increased CO2 production. Type 2 failure. So COPD gives type 2 failure. And it is caused by disease that damaged lung. It is caused by ventilation being insufficient to excrete. Embolus, 1 failure. COPD, 2 failure. What is there? Ventilation is inadequate. There is obstruction, lung damage. This is restriction. Exclude any area problem, research a property, give oxygen, type 1 failure, positive pressure, respiration can improve PO2 if high flow oxygen. In type 2 failure can be improved with bi-level positive pressure, BiPAP. Type 2 failure you need bi-level. Involve senior ITO mechanical management, take the history, regulate breath monitoring, ABG monitoring, adjust, give bronchodilators, antibiotics. Patients with requirement of more than 40% to keep oxygen saturation and should consider for observation ITU. Now note that students, we will remember being told that high concentration of inspired oxygen can ultimately stop patient breathing due to loss of hypoxic drive. Hypoxic drive rather than raised PCO2 drives in some patients. However, in reality, this is unusual, and a junior doctor should not be afraid to give hypoxic oxygen flow. Give a hypoxic patient of high flow oxygen when oxygen saturations are less than 90. Respiratory depression in this situation does not occur immediately, and delivery of oxygen is more important at this stage. Carefully monitored. This is so important. What are the different scenarios in ITU will lead to respiratory failure? Respiratory current management is patient aspirated who has aspirated into lungs. Look for the particulate small acid damage to the alveoli, infected material, lung abscesses, opportunistic infection, candida, empyema, diagnosis, ARDS. This is failure from severe acute lung injury. ARDS caused by component systemic SIRS, multiple organ failures, leakage of the fluids interstitium and poor lung volumes, consistency and baby lungs because some smaller than small it may resolve. Diagnostic feature of acute lung injury: ultrafiltrates, chest X-ray ultrafiltrate, pulmonary capillary wedge pressure is very low, less than 18. So infiltrates are not due to cardiac pulmonary. So cardiac cause, if it is there, it will be high, while hypoxemia with ratio more or less than 40, ARDS criteria is hypoxemia. Others, acute lung injury and ARDS, direct, indirect, direct chest trauma, aspiration, pneumonia, indirect hypovolemia, hypovolemia. Management of acute laryngitis is almost entirely supposed to treat the underlying cause if possible. Reposition the patient. Prone position has to be given. Careful fluid restriction, corticosteroids, ventilation management, optimization of oxygen is achieved by mean arterial pressure. So PEEP, positive end expiratory positive pressure. Positive end expiratory pressure, increase PEEP. Severe nitric oxide may be used to reduce oxygen ventilation. So nitric oxide therapy is also helpful. It causes vasodilators. Outcome of ARDS, respiratory monitoring and support, nasal intubation. This is technique contraindicated in apneic patient whom mid-phase or basal phase structure. Orotracheal intubation, diameter it has to be 8 to 9. Cuffed tube, it has to seal, cause stenosis, unconscious patient cannot maintain, Glasgow less than 8. Risk of upper airway obstruction, impaired gag reflex, required mechanical ventilation, unable to suction, unconscious, risk of upper airway gag reflex. Just see this, mechanical hypoxia, anesthesia for surgery, suction or secretions. Endotracheal tube has to be there, ambu bag has to be there. You don't lever it on the teeth. Auscultation, hazards, esophageal intubation, complications, skill operator. Prevention of pressure response or laryngoscopy, IV fentanyl or lidocaine, especially if risk of cricoid pressure has to be given impetigo into the body of C6 vertebra. Success methonium has a rapid onset, character of fasciculations, alternative airways, cricothyroidectomy, percutaneous tracheostomy. Tracheostomy is a long-term management, is performed percutaneous, also time-consuming. Prolonged ventilation is required. Tracheostomy is done. Patients who are maintained on the bulbar palsy, is there a contraindication? 1% lignocaine posterior bronchoscopy, trachea. Tracheal stoma should be located. Tracheal stoma should be located between second and fourth tracheal rings in superficial 3 cm horizontal incision, large bowel. Cuffed tracheostomy is passing guide one intercostum tube. Reduces work of respiration. Complications of mechanical ventilation may be barotrauma, pneumothorax, pneumomediastinum, pneumoperitoneum. These are barotrauma. Questions are coming on these barotrauma. Cardiovascular, it decreases the venous return. This is again a question, decreases venous return. High intrathoracic pressure, increase pulmonary vascular resistance. It may lead to gastric dilation, external disconnection. Achieved by adding valve to the assisted breathing circuit, expiratory pressure is not allowed to fall below. Disadvantages, physiological shunting. PEEP, this is PEEP, positive, so we do not allow to fall below this. Continuous positive pressure, spontaneous ventilation, tiring, intubation, intermittent positive pressure, ventilation, high pressure curve, controlled mechanical ventilation, it is volume control, intermittent mandatory ventilation, spontaneous breathe in between. Allows patient, IMV allows patient to synchronize. ARDS, pressure control ventilation. Assist control trigal ventilation is patient's own rhythm to the trigger. Removing off from the ventilator is weaning. Patient must be recovered from the original problem, require ventilation. Conscious, metabolic state, cardiovascular function, state of mind to be considered. Synchronous intra-IMV, SIMV. Intermittent. SIMV rate is reduced until breath is spontaneous and supported by pressure support. TPs before extubation. The most successful method of weaning is spontaneous breath from the patient supported by pressure support. Spontaneous breath. Extubation, patient may be able to breathe spontaneously. Cuffed reflex has to be there, conscious and cooperative. So essential that secretions are cleared in the ventilation. Patient cannot cough, especially all these are there. So pain is, now coming to the pain control, there are 4 processes. Transduction. Transduction, you give anti-inflammatory. Transmission, local anesthesia. Modulation, tense, perception, opiates. So these are the ways. Transduction, you give sensory non-steroidal anti-inflammatory, inhibits by prostaglandin. It inhibits prostaglandins. Transmission is by A fibers, these are fast, and C fibers are slow, burning, sharp pain by the fast. So, although C fibers pain is not well localized, it results in immobility. A fibers terminate at the two plate dorsal lamina and 1, 2. C fiber terminate lamina 3 and 4, also called as substantia gelatinosa. These primary afferent fibers synapses into second order neuron in the dorsal horn and transmitters here the substance P. First order neuron cross, second order neuron lateral spinothalamic tract, third order neuron thalamus, internal capsule, postcentral gyrus. So this is termination. A fibers reach the cortex, C fibers reach reticular formation. They terminate in cortex as well as retinal. So modulation of pain, central mechanism. Some are the central mechanism are descending in OSD. The tracks originate pre-acute ray matters. These are enkephalins and release cause pre-synaptic inhibition of incoming fibers. Throughout the descending anti-nociceptive tract, there are receptors that respond to morphine, and the brain has its own natural receptors, endorphins and enkephalins, which act in this pathway and opiate analgesics via these opiate receptors. Morphine, these are called as mu receptors, endorphins and enkephalins. The centrally it inhibits at the central level, third order neuron or second order neuron. Spinal mechanism is again opiate receptor direct spinal thalamic release substance P, primarily secondary, and these mechanisms exploited by epidural injections. And mechanical inhibition of the pain, it is by the tense at the local site stimulation of mechanical receptors, where pain originates can inhibit the pain by stimulating A fibers. So again you have seen these A fibers. Modulation, tense, perception, opiates, higher level, and local anti-inflammatory. Perception of pain occurs at thalamus and sensory cortex. Referred pain, this is a pain which is received to occur in the part of body topographically distinct from the source. Branches of the visceral fibers synapse in the spinal cord with the same second order neuron that receives pain fibers from the skin. Therefore, when visceral pain are stimulated, pain signals from the viscera can be conducted to the second order neuron, which normally conduct pain signals from the skin. The person then pursues the pain as originating from skin itself. So this is the referred pain, and visceral pain is viscera, sensory receptors, no other modality of sensation except pain. The localized damage to viscera causes severe pain. So stimuli can diffuse stimulation of nerve ending, viscous, and cause pain via ischemia, smooth muscle spasm, distension of the hollow viscous, and visceral pain from the thoracic and abdominal cavity transmits sensory nerve fibers which run in the sympathetic nerves. These fibers are C fibers. Transmit burning and aching sensation from visceral pain fibers entering the spinal cord through the sacral parasympathetic. So what is that? Sensory nerve fibers, visceral pain from the thoracic abdominal cavity are transmitted to the sensory nerve fibers which run in the sympathetic nerve. These fibers are C fibers, transmit burning and aching pain. Some visceral pain fibers enter spinal cord through sacral parasympathetic fibers, including those from the distal colon, rectum, bladder. Note, the visceral pain fibers may enter the cord via cranial nerves, glossopharyngeal, and vagus nerve, which transmit pain from pharynx, trachea, and upper esophagus. So it can be sympathetic, which carries the burning and dull pain, or parasympathetic from colon distension from the viscera. These are the sympathetic and parasympathetic fibers which enter. If the disease affecting viscous spreads to the parietal wall surrounding viscera, the pain is pursued with sharp and intense. The parietal wall is innervated from the spinal nerves. A fibers. So visceral pain is referred to as dermatomes on the body surface. The position on the surface of the body to which pain is referred depends on segment of the body from which organ has developed embryologically. The heart originates in the neck and upper thorax. So visceral pain fibers from the surface of the heart enters the cord from C3 to C5. Visceral pain is referred to as dermatomes on the body, the position on the system surface of the body to the pain, embryological development. So heart originates in the neck, and so visceral pain fibers from the surface of the heart enter the cord C3 T5, and dermatome segments cardiac pain derived from the foregut itself is upper abdomen. Pain from the organ deriving from the midgut in the mid abdomen and hindgut is felt in lower abdomen. And what is parietal pain? This is transmitted via spinal nerves, which supply the external body surface. Good example is acute appendicitis. A colicky umbilical pain appears to move to the right iliac fossa, becomes constant. Visceral pain is transmitted via sympathetic chain at level of T10. This pain is referred to the dermatome corresponding to the area around umbilicus. This is colicky pain associated with obstruction of the hollow viscus. Initially there is stretch. So that stretch is the T10. When inflamed appendix touches the parietal peritoneum, then the impulses via sympathetic nerves to the level of L1-2. This constant pain, which is will be localized in right iliac fossa, a third of the distance from. So this shift of the pain is basically when inflamed appendix touches the parietal peritoneum, then only you get a right iliac fossa pain, or when you are trying to. That is the thing. Method of assessing acute pain: subject to measure of the acute pain, none, mild, moderate, severe, ranging from the worst pain is 10 to 0. Smiley faces, sad faces for children. Most are indirect: blood pressure and vital capacity. Inadequate analgesia. What are the causes? Post-operative pain relief may be due to expectation of the patient, nursing. Prescription method: prophylactic, inability to use intolerance pain relief method. Harmful effects of untreated acute pain: it may increase heart rate, blood pressure, respiratory rate may go down, splinting of the chest wall, decrease gastric emptying, retention of urine, musculoskeletal spasm, anxiety, fear, sleeplessness, neuroendocrine, catecholaminemia, all these. So, how to manage the post-operative pain? The realistic aim of the pain is not to abolish the pain completely, but to ensure that patients are comfortable and have return function. The preventing development of pain is more effective than treating established pain. So, preemptive analgesia before surgical trauma, parental opioids, regional blocks. It's difficult to produce safe, effective analgesia for major surgery with single group of drugs. Monomodal therapy. Therefore, better analgesia achieved by combination of drugs. These are part of pain pathway modulation. Multimodal therapy has to be used. Choice should be least painful incisions. Post-operative analgesia used for non-opioid analgesia, initially paracetamol, NSAIDs. Use of regional local analgesia techniques. Epidural, peripheral blocks, or major surgery opioid needs to be addition to enhance the analgesia. Acute pain versus pain service. Day-to-day management, multidisciplinary team, medical, nursing, and pharmacological expertise has to be there. Patient control anesthesia has to be there. Chronic pain service, the physical neurological system rewiring involve physical neurological system rewiring, behavioral psychological factors. Management strategies include acute chronic pain state, multimodal therapy, etiology of chronic pain, neurological system rewiring. The chronic pain state that are microscopic sensor neurogen in the dorsal horn, spinal cord, brain, neural connections are altered, releasing central plasticity and results in change in reduced pain threshold in which exerted local response to painful stimuli termed as hyperalgesia. Connection of mechanism of neurons to movement pathway, non-painful stimuli are received painful, resulting in allodynia. Examples of plasticity of neural systems are phantom limb. Behavioral and psychological issues, depression, anxiety, and all of these. Chronic pain may be skeletal, spinal, joint, muscle, neuropathic, burning, and commonly backache and headaches. History of injury, medication use, comorbid illnesses, pain history, amount, duration, and constant shooting versus burning condition, physical, psychological, all these. Behavior, multimodal therapy of chronic pain, functional disability, nurses, psychologists, physiotherapy, NSAIDs, tramadol, codeine, flare-ups, morphine tablets, transdermal, fentanyl, antiepileptics, GABA, pain in malignancy is combination of neuropathic pain, no superior due to tissue damage. Management of malignant pain. What is malignant pain? WHO analgesic ladder has to be used. Aim is to regional blocks, celiac plexus block, radiotherapy for pain relief, and CT guided. Pharmacology of pain. WHO step 1 simple analgesic paracetamol NSAIDs. Step 2 is compound analgesic comodal diazepam, and step 3 is opioids, oral morphines. So morphine. Step 3 coronal diazepam. Routes of administration: sublingual, rectal, inhalation, oral, intramuscular, intravenous, mildly analgesic. Side effects of paracetamol overdose may cause liver damage. Non-steroidal act peripherally. So they have got oxygenase, cyclooxygenase inhibitors. These are the side effects. Bronchospasm may cause gout, displays warfarin. Opioid analgesics, again the receptors are mu, kappa, and delta. 3 types of receptor, mu, kappa, delta, basically opioid. Side effects of respiratory depression can be the side effects: nausea, vomiting, and hypotension. Meiosis intolerance, delayed gastric entry, constipation can be there. Oral is codeine phosphate, tramadol, morphine sulfate solutions. Take a surgery 3 to 4 days after major surgery. Patient control anesthesia, microprocessor control pumps are there. Advantages. So, what are the different intravenous drug delivery system? Venous access may be achieved by peripheral or central. That is, peripheral is easily peripheral veins of the extremities, central by the central large venous, femoral vein, intrajugular vein, subclavian vein, peripheral venous system. A 12 gauge cannula, or this can be introduced. 24 gauge for the small children. Indications and contraindication is blood give fluids, blood sampling, drugs, central venous line. Contraindication: local sepsis, puncture. Complications: this may lead to thrombophlebitis, subcutaneous hematoma. Common sites for peripheral vein access: dorsum with basilic vein on the medial side, medial cephalic vein, external jugular vein, long saphenous vein at the ankle. Dorsum venous cut down is just hypoglycemic shock, peripheral vein in the burns and all patient, where most of the time venous cut down, then IV access, circulatory column when established. Patient is supine with the medial ankle or the venous on the lower leg. You can see this is the basilic vein, cephalic vein. These are the locations where you can put peripheral vein, and this is venous cut down. Long saphenous vein is in the site of medial malleus, incision saphenous vein at the ankle. You just take a transverse incision, identify distal part is ligated, and then open the vein and put the catheter in this. That is the venous cut down. Then complication hemorrhage, then central venous catheter, potentially dangerous procedure, and hypovolemia patient should be performed only by experienced practitioners. Central venous catheter, superior vena cava may reach superior vena cava, and this via it can be to peripherally from basilic vein, or it can be directly side subclavian jugular vein catheter introduced through the through cannula technique. Needle is into the vein. It is called a Selnigan's technique. Flexible metal guide wire is fast, then coiling into. Then there can be Hickman's or double lumen, triple lumen, Hickman, or wide bore cannulas. Central venous anatomy. Then catheters are inserted particularly may be placed under the direct vision for this. Then subclavian vein. The axillary vein continues. As axillary vein is continuous, subclavian vein crosses the border. Interjugular vein is closed to the subclavian behind it, and dome of pleura. So thoracic duct enters the subclavian vein at the origin on the left side. That's why cannulation on the right side is safer. Internal jugular vein runs down the neck. It comes from the lateral. So lateral to internal jugular vein comes to lie lateral to internal and common carotid arteries, deep to intercostal muscles, and join the subclavian to form brachiocephalic vein behind the sternoclavicle. The vein may be punctured from three sides. So it can be punctured posterior to the border of sternomastoid. Most common posterior to the border of sternomastoid. Anterior to the border. This is what we are doing. The vein may be punctured from three sides. Posterior border of sternomastoid. Anterior border of sternomastoid near its lower end between the two heads of sternomastoid. First route is most commonly used. Posterior border of sternomastoid. So it is lateral to internal common carotid artery. Pulsations which you are feeling, you have to go lateral to that. Central venous access fluid, it is used for fluid, drugs, cytotoxic drugs, total parenteral nutrition, monitoring, patient positioning. Again, this is line is put blunt. So this is about the details of the 10 ml local anesthesia is introduced, then CVP line kit is there, sterile gauge, ultrasound guided. It is ultrasound guided for identification of target vessel. Once you have got ultrasound guided, it is safer. Then close the X-ray position of patient should be supine, should be supine with head tilt down. Head up to prevent air embolism, distension of the veins. So head up should not be there. Head should be down. So if by chance there is embolism, it will not go above to the brain. It will go down. Because critically patient do not tolerate this position for longer period. Position should be under aseptic technique. So glow and subclavian approach. Immediately below the junction. Where is subclavian? Now you can go subclavian approach. Internal jugular approach. Immediately below the junction of lateral third and medial 2/3 of the clavicle. This is for the subclavian. Tip towards the sternal, walking the needle tip down the undersurface of clavicle. Palpate the sternomastoid and place the finger of your on the pulsatile right carotid artery and place gentle medial to introduce the needle at the midpoint of anterior border of the sternomastoid. Now this is the technique. The chest X-ray radiograph to exclude pneumothorax has to be exclude. Check the catheter tip. Complications: pneumothorax, hemothorax, puncture of adjacent artery. So subcutaneous implanted vascular access, this is porta cath, infused porta. This is for the chemotherapy in children, also intraosseous approach. In emergency patient, the site, identify the site approximately 1.5 cm below the tuberal tuberosity anteromedial surface, direct puncture, infusion pump. This is fluid challenging using invasive measuring, colloids, dose. This is about steroids, colloids. Potassium is replaced maximum 20 millimoles per hour. Blood pressure, mean arterial pressure, AM 60, systolic 90. Cardiac positive inotropes, dobaxamine infusion, adrenaline, inotrope, vasopressor, chronotrope, beta receptors.